Thank you all for joining me. I'm so impressed that you're spending your evening after a long day of work during your personal time to learn more about restorative dentistry. Your patients are so lucky to have you because you're taking the time to learn more, to be better, so you can be better for your patients. So I'm so honored to be amongst you all. So today we're going to be talking about my favorite restorative things. It's a play on, my favorite things. We are going to talk about a lot of different products, including SDI. So thank you, SDI, for sponsoring. And about me, I am a general dentist practicing in Toronto. I'm an associate, and I spent the majority of my career working in public health. I'm opening up my own office, which will open this August. And founded the New Dentist Study Club, and I host their podcast. And I'm proud to be on the Catapult Speakers Bureau. And I graduated from the University of Toronto in 1999. So it's great to see some Canadians here joining us. So how about this question? Do you get frustrated doing restorations? I sure do. Especially if I have to do like back-to-back restorations, back to back. That is so stressful. It is harder to do those types of restorations than it is to do like, surgical extractions or implants or take out third molars. Restorations are hard and we can make it easier. That is our job today, to find out to learn some tricks and to learn about some great products and instruments that can make your life easier. Because I I used to be ashamed of how bad my dentistry was. I thought of myself as a crappy dentist. I used to be embarrassed, in those recall exams when the hygienist would put up the bite wings and I'd see, the work that I just did and how bad it was. And I was getting really down on myself. And I was too embarrassed to talk to my friends about it. But one day I was at a dental meeting and I saw that there was, a lot of sponsors. So I went up to one of the sponsors and I just said, like, can you help me out? And she did. She gave me like lots of tips. She gave me some products to try. And ever since that, I just kept getting better and better. I kept learning about new products, trying them out. Whenever I go to dental meetings, I'd go to all the booths and learn as much as I can from the exhibitors because they are experts in their field at the different products that they sell. So my pro tip to all of you is please speak to your reps because they are going to help you so much in dentistry. So these are the problems that I used to have. How deep should I drill? And then with my band and wedges, like I'd have trouble putting them in. They would be coming off, couldn't isolate properly. My contacts were open. The marginal ridge wasn't contoured well. It was like sticking up. I'd get recurrent decay and post-op sensitivity. And so I found tips to deal with all of these restorative problems, and I'm thrilled to be sharing them with you today. And if you have any questions, please put in the Q&A or the chat, and at the end of the program, I will answer your questions. So our goal is let's make restorations fun again. So I'm going to tell you what I do to make restorations fun again. I have this bag. You can see it here. And this bag has all of my favorite restorative things. And I carry it with me to all of the different clinics I associate with. Even when I do volunteer work, I take it with me. Even when I go up north to work in Indigenous communities or down south to do free dentistry in the Caribbean for dental outreach, I take that bag. Because with the stuff in that bag, I get better clinical outcomes. So my patients are happier and I'm happier because I have less stress doing dentistry because these all make my life easier. And I'm thrilled to be sharing it all with you today. So here are learning objectives. We're going to implement the latest evidence-based recommendations on caries removal and restoration. Then we're going to choose the best tools to use in challenging situations. And at the end, we're going to apply different isolation techniques. So learning objective 1, implement the latest evidence-based recommendations on caries removal and restoration. And I have some polls throughout the hour, so please stay close to your screen so you can do the polls. So this was life-changing. In July 2023, The Journal of the American Dental Association came out with these articles on how to remove decay and how to restore the tooth. So I love guidelines because then that means I'm doing the best for my patients by following the guidelines. So for moderate, here's a poll question number 1. Lisa's going to put it up for you so you can answer. For moderate or deep caries lesions, for caries removal, what are you going to do? What technique is recommended? Remove all the caries, so that's non-selective caries removal. Selective caries removal, which is partial removal, you're just taking away the infected dentin, leaving the affected dentin. 3, stepwise caries removal, or 4, no caries removal. Which is the best technique for moderate or deep caries? Okay, we're going to give you a few seconds to put your answers in. Okay, Lisa, what is the response? Okay, 53% of you are correct. Selective caries removal, partial caries removal. So let's talk about that some more. Selective caries removal. So with selective caries removal, we are just removing dentin, the decay until we get to soft or firm dentin. We do not have to go all the way to hard dentin, because if we go all the way to hard dentin, you might get all the way to the pulp. And you're also going to increase sensitivity the deeper your drill. So selective caries removal, we're just removing the soft, mushy stuff and then getting to the softer firm. With complete caries removal, that's great for smaller areas of decay, where you drill away the decay until you reach hard dentin. Stepwise removal, I only did this in dental school, where for big lesions, we would remove the soft dentin, put a temporary filling like glass ionomer, and then tell the patient to come back in 3 to 6 months. And then hopefully there's like a harder dentin layer there now. Remove the temporary, remove any soft dentin until we reach firm dentin, and then give the final restoration. No caries removal, that is actually a technique that's used in the Hall crown with pediatric teeth, where we don't remove any caries. We just put a stainless steel crown over the tooth. And because the tooth is well sealed, the bacteria inside don't proliferate. And I've used this technique and it works. Okay, so for moderate to deep lesions, it's selective caries removal. We only have to remove enough decay to reach soft or firm dentin. So look at this picture, this cross-section of the tooth. Areas number 1 and 2, that is your infected dentin, your soft, mushy stuff. Remove that. You can leave areas 3 and 4, the affected dentin. And then just put a liner and a base. And then the materials in that liner and base will kill the bacteria in areas 3 and 4. Let's take a look at another picture. Take a look at this. If you keep drilling away at that affected dentin, look what's going to happen. You are going to hit the pulp and get a pulp exposure. So our goal here is not to hit the pulp, not to drill too deep, because as soon as you hit the pulp or get close to the pulp, you are decreasing the success rate of your restoration. So the chance for survival are excellent if the tooth is asymptomatic and well sealed, even if residual caries remains. So we remove the infected dentin. There's affected dentin left. So now that's called an indirect pulp cap. We're getting close to the pulp, but we don't want to remove any more decay. So what we're going to do is stop, and we're going to place a liner. So what is the best material for an indirect pulp cap? So Lisa, can you please put up the second poll question? Is it glass ionomer, MTA, calcium silicate, calcium hydroxide, or the type of liner is less important than having a well-sealed restoration? I'll give you a few seconds to answer that. Okay, 42% of you got it correct. So it doesn't matter what material you use, but what's more important is that you have a well-sealed restoration. And just to let you know, for MTA should not be used as an indirect pulp cap. because it has a long setting time. So MTA is great for pulpotomies, partial pulpotomies, even direct pulp caps, but not for indirect pulp caps. The other ones are better. Okay, thank you. You guys are doing great. So the type of liner is less important. That's the correct answer. So the type of liner is less important to success in the placement of a well-sealed restoration. So well-sealed restoration means the bacteria will significantly be reduced, the soft lesions will become hard, and the radiolucency will stay the same or even decrease. So what are we going to use for indirect pulp cap liners? I like using IonoSeal. It is a glass ionomer liner. I also like using SDI Riva, which is glass ionomer. Vitrabond is also glass ionomer. So these top three are all glass ionomers. Limelight is a resin-based and it releases calcium, phosphate, and fluoride. Dical is calcium hydroxide, and Theracal is calcium silicate. So here are your indirect pulp cap liners. Okay, I have this warning sign. Look out. I hope you guys are ready for this. Okay, so say you're doing restoration of molar, you drilled away all the decay, and you're like, let me just go in there one last time to make sure it's all clean. And this happens. I don't know about you, but when I see this piece of like red inside the tooth, I'm like, oh, is there something on my glasses? Do I have to clean that off? Oh, did some blood from the gum get into the tooth? Because that's not a pulp exposure. I do not want to deal with that. So after I get through that, denial and realize it is a pulp exposure, I have to get ready for a direct pulp cap. So what material should we use for a direct pulp cap? What is your direct pulp cap protocol? You know what mine is? I don't have one because I don't ever want to have to do this. It stresses me out. You can see the look on my assistant's face when this happens because she knows that I'm about to panic. So I'm like, I don't want to have a protocol because I don't want this to happen. So I avoid it by not drilling too deep and just doing an indirect pulp cap instead. But if this does happen to me sometimes too, these are the materials we're going to use. We are going to control bleeding with a cotton pellet with water, saline, or bleach, sodium hypochlorite. Do not use Hemodent, astringent. It's going to be water, saline, or sodium hypochlorite. Then once the bleeding stops, it should only take a few minutes. We're going to apply calcium hydroxide, which is Dical, calcium silicate, which is Theracal, or MTA. Then we're going to place a well-sealed restoration. So here are the direct pulp cap materials: calcium hydroxide, calcium silicate, or MTA. I like using neopathy because you don't have to mix it. It comes in a little syringe. You just squirt a little bit out. I get a cotton pellet, stick it on the little bit of the neopathy that comes out, and stick it into the tooth. And with a wet cotton pellet, you can dab it dry and then put your restoration over top. So that had to do with removing decay. So we removed the decay. Now we have to restore the tooth. That same journal, by the Journal of the American Dental Association, talks about what materials we should restore with. So it mentions all of this flowchart for primary teeth. So I'm going to summarize it here. For primary teeth, class 1 restorations, use composite resin, resin modified glass ionomer, preformed crowns, or glass ionomer. For posterior class 2s, composite resin, resin modified glass ionomer, or your stainless steel crowns. So they're almost identical. The only thing is with class 2, we're not going to use glass ionomers because glass ionomer is not strong enough. Resin modified glass ionomer is strong enough because it has the strength from the composite resin. And just to let you know that in Canada, we pronounce it composite resin, not composite. So sorry about that. Okay, for permanent teeth, they have this flow chart of what to do in which situation. I'm just going to summarize it here. This is a lot easier. It's very similar to primary teeth. Look, for class 1, composite resin, resin modified glass ionomer, amalgam glass ionomer. So the only difference is for permanent teeth, they put amalgam, not stainless steel crowns. For posterior class 2s, composite resin, resin modified glass ionomer, and amalgam. Then the only difference is amalgam instead of stainless steel crowns. So in many countries globally, they are banning amalgam, and manufacturers have actually stopped making amalgam. So eventually we're not going to have amalgam anymore. And so I've also strayed away from it as well. And I'm using more composite resin, resin modified, and glass ionomer. So here's a case that I did just last week. So it was a 4-year-old girl. You see huge cavity on her upper primary molar, first molar. And what would you do in this case? Remember, what's the protocol? We're not going to remove all the decay because we're going to hit the pulp if we do that. So I did selective caries removal. Then I placed IonoSeal. Then I placed Luna, like etch, bond, Luna Flow, Luna 2 composite, A2, and then the final restoration. And then you can probably see in that second picture, there's a little piece of plastic on the buckle. That is, I was using a dry shield for isolation, and we're going to talk about that later. So I could have also used glass ionomer. I guess it's class 1, or I could have used resin modified glass ionomer. For permanent teeth, for class 3s, the journal recommended composite resin, nanocomposites, or hybrid resins. So basically resins for aesthetics. But look at this, for root surface, composite resin isn't on this list. They do not recommend composite resin for the root surface. Instead, they recommend glass ionomer, resin modified glass ionomer, and amalgam. So let's take a look at an article talking about that. This article says glass ionomer showed clinical performance significantly higher than composite resin in regard to retention. And then when it comes to other parameters, glass ionomer was similar to composite resin, other parameters being like strength and aesthetics. So glass ionomers have better retention to root surfaces than composite resin. And this is a systematic review and meta-analysis. These are the highest levels of scientific evidence. They are saying do not use composite resin on the root surface. Glass ionomer has that flexural strength, which will prevent your restoration from popping off. So if there's one thing differently that you can start doing tomorrow is stop using composite resins for root surfaces and start using glass ionomers and resin modified glass ionomers. So here's our poll question. Should all get this correct. Lisa, can you put the poll up? Which of the following is the best material for a root surface restoration, or a class 5? Glass ionomer, resin modified glass ionomer, composite resin amalgam, or is it glass ionomer and resin modified glass ionomer? Which ones are the best? Give everyone a few seconds to answer. What would you do in this case with this patient with all these abrasions and infractions? Okay, Lisa, what's the answer? Great, 61% of you got it correct. It'd be glass ionomers and resin modified glass ionomers. Those would be the best. Okay, so both A and B. Advantages of glass ionomers. Very high fluoride release, so it's going to prevent recurrent decay. It's going to remineralize any decalcified areas. It chemically bonds to the tooth, not physically, so that aids in retention. It has high flexural strength. So on that cervical area, there's a lot of flexural stress. So you need a material with high flexural strength, like glass ionomer and RMGI. There's going to be less post-op sensitivity. It's going to be very resistant to acid attack because of all that fluoride. And there's no polymerization shrinkage with pure glass ionomer, which is self-pure. You don't have to worry about the light and polymerization shrinkage. And look at the great aesthetic results. So please start using glass ionomers and RMGIs for your root surface, your class 5 restorations. So here's the case I did. I volunteer once a year down south with a charity called 1000 Smiles, and we go to the different Caribbean islands. So this was in Grenada. So I lifted up the patient's upper lip. This was his chief complaint. And you can see root surface caries. So what did I use? I used glass ionomer. And it's going to prevent recurrent decay, sensitivity. It looks great. The fluoride's going to be released there, and it will prevent acid attack, high flexural strength, and chemical bond to the tooth. So why do I use, Riva glass ionomer and RMGI compared to other brands? It's because it releases way more fluoride than the other brands. And that's what I want. I want fluoride. I don't want acid attack of the restoration, and I don't want recurrent decay. I also use glass ionomer in the sandwich technique, or when I do it, I like to call it the sandwich technique. And so what I do is if there's a subgingival restoration and I can't isolate the base of the box, like there's blood, there's saliva, gingival curricular fluid, I can't get it dry. What I'll do is I'll put self-cure glass ionomer at the base, and then I will put regular composite over top. So that's the sandwich technique. And the great thing is that fluoride that in the glass ionomer is going to prevent recurrent decay because that's an area that's hard for the patient to clean. So I have some tips for glass ionomers because I only started using glass ionomers about 5 years ago. Before that, I didn't use it because I was like, it's sticky, like, it sticks to my instruments. I don't know how to manipulate it. My restorations looked awful at the end. But then I learned these tips, so I'm going to share them with you. First of all, glass ionomer or RMGI, either one, it's not the same as composite resin. So with composite resin, as soon as we put it in, we start sculpting it. We're fiddling with it so much. The less you handle glass ionomer, the better. So stop fiddling with glass ionomer. Also, after you place it in, wait 20 seconds before you touch it. So that's about the length of time as curing light. So you can wait 20 seconds and then you're going to start handling it, but not too much. And if your instrument sticks to it, then I recommend you just get some flowable composite, put on the end of whichever composite instrument you like and manipulate it a little bit. And remember, if you're using resin modified glass ionomer, there's resin in it. So that means you can only put it in 2 millimeter increments. The only one you can fill up, fill completely and not worry about how the depth of the preparation is with self-cure glass ionomer. You can bulk fill that, but if it's light cure glass ionomer, you have to use 2 millimeter increments. So those are my tips. Okay, I have another tip for you. There is a really cool product called Stella, and it's a self-cure composite, and it's unlimited depth of cure. So if you have a 7 millimeter prep, you fill the whole thing up, you overfill it, you wait 4 minutes, and then you can polish it. And the great thing about self-cure, not only is it unlimited depth of cure, you get a gap-free interface. That's right. You're not going to get, a gap between the restoration and the tooth because there's no polymerization shrinkage. When we shine a light on light cured composite, the composite pulls up towards the light and creates a little gap. With Stella, the material actually goes into the tooth. So there's no gap. It's a very strong material, high compressive and flexural strengths. There was a recent study saying that the strengths are even higher than most composites we use. And it contains fluoride, calcium, and strontium. It releases 10 times more fluoride than light cure composites that have fluoride. And you're going to have less post-op sensitivity. So Stella comes either in a syringe or a capsule. And it's very easy to use. You just use a primer, not your etch. You put the primer inside the prep. leave it there for 5 seconds, blow it dry for 2 to 3 seconds, and then you fill the entire preparation with Stella. You overfill it because it's going to sink a little bit. And then after 4 minutes, you're going to wipe off the oxygen inhibition layer because it's going to feel like gummy on top. If that doesn't work, you get a really high amount of alcohol, like 99% alcohol if you can find it, and with some gauze and wipe the oxygen inhibition layer off, and then you just polish it. So check out Stella. So I talked about different products here. Let me tell you when I use what. So glass ionomer self-cure. I use it when I can't isolate the area, like there's blood, saliva, gingival coagulative fluid. I can't keep it dry. I'll use glass ionomer because glass ionomer is moisture friendly. I will use glass ionomer, I should say over SDF, over silver diamine fluoride. I will use it for class 5 restorations as liner and bases. I use it on uncooperative patients, like young children. I will just place a glass ionomer and I don't have to worry about etch and bond, and it self-cures. So you can get fast set, which like sets in a minute. And I also use glass ionomer as sealants sometimes. Okay, how about resin modified glass ionomer? I'll use it for class 5s, liners and bases, uncooperative patients. I also use it as a temp, like in between like endo appointments, I will put RMGI. And for hypomineralized teeth, they are those chalky teeth. Composites don't bond to them very well. So I will use a resin modified glass ionomer. I find hypomineralized teeth get recurrent decay easily, they chip easily. So I will use RMGI. Composite resins I use almost for all my cases, but I always make sure that it's a prep where the light can reach the bottom of the prep. And if it's an extremely deep prep, then I will use self-cure composite resin. And also if I want to like do several restorations at a time, I want to save time, so I'll just bulk fill them all with self-cure composite resin. So self-cure composite resin can be used, for your regular composite resin as well. Okay, so there's another journal from JADA, and this was on non-restorative options. That's right, when you don't have to pick up a drill. This is fantastic. We can use it on primary and permanent teeth. Let's prevent decay, prevent picking up the drill. So we have 2 different flow charts for primary and permanent teeth. Let me just summarize it. This is basically it. Non-restorative options are silver diamine fluoride, fluoride varnish, resin infiltration, and sealants. So this journal came out before Curodont came out, which is why enamel guided regeneration is not on here. In Canada, we don't have Curodont. I'm just waiting for Health Canada to approve it because I'd love to use it just like you're using it in the States. I love using silver diamine fluoride. I use it all the time. So let me tell you when and I use it. Look at all these cases where I would use SDF. 2-year-old has decay on just like a couple of teeth. I'm not gonna, send her for general anesthesia. I'll just put SDF on those small areas of decay and then tell the parent, okay, keep bringing your child back, regularly. We can reapply the SDF. And then when your child's more cooperative, we can do the restorations. Or how about this decay of an upper third molar on the distal? Like that's a really hard area for me to get. If I can't reach that, especially if the patient has like really big cheeks, can't access it, I will just apply SDF. Or how about patients who have medical contraindications to dental care, but they have decay? How can I help them? I can help them with SDF. I have friends who work in long-term care and they use SDF on most of the patients there. How about someone who has rampant decay? That's their one time that you can see them. For example, with the volunteer work that I do, I'll apply SDF because there's no way we can fix all of those cavities in that one appointment. Or if there's recurrent decay around a crown, I will tell the patient, hey, instead of redoing the whole crown, we have this option. We can put SDF, monitor it, and then see if you need to get the crown replaced. So some great ways that you can use SDF. Here's a case that I did. 2-year-old, the only cavities she had were between her two upper central incisors. I applied SDF. So it stopped the cavity from getting worse, and it doesn't look too bad either. Okay, here's a case from my friend. He's a prosthodontist, James Tonagay, and he's a prosthodontist. A general dentist referred this case to him. This patient's in her 80s. Look at the huge decay on the bridge abutment. So probably the reason why that general dentist referred this case was to say, hey, extract the tooth and do an implant supported denture or, traditional denture here. James did not do that. So I'm going to show you how the tooth looked. What James did was teach the patient how to use a water pick to keep the area clean. And then he brought her back 2 weeks later, and she kept it clean. The gingiva was nice and healthy. And then he applied SDF. And then 2 weeks later, he brought her back again, touched the SDF. It was nice and hard. The decay's arrested. So he put glass ionomer over the lesion. And 2 years later, the patient's still asymptomatic. The bridge is still there. So fantastic way to use SDF. Which restorative material should not be placed immediately over SDF? Is it glass ionomer, resin-based glass ionomer, composite resin, amalgam, stainless steel crown, or resin-based glass ionomer and composite resin? Which material should not be placed immediately over SDF? Great, 50% of you got it correct. It's resin-based glass ionomer. And composite resin, why? Because if you put SDF and then you shine a light over top of it, the silver from the SDF will leach into the composite RMGI and the whole tooth is going to look silver. It's pretty cool to see, but you don't want to do it in a real patient. So for example, for that case with James, if you wanted to do the restoration on the same day, he would have put the SDF and then put just self-cure glass ionomer over top. And that way, there's no light. Or he could have put amalgam. But he wanted the benefits of the fluoride from the glass ionomer. So do not shine a light over SDF. You actually have to wait at least 2 weeks after placing SDF before you can shine a light on it. So the answer is B and C. So here are my tips for handling SDF. Number 1, do not place it close to the pulp because it can irritate the pulp. So if you're getting close to the pulp, use a liner, use a base. Use liners like glass ionomer. You can also place a liner like IonoSeal, glass ionomer over top as a base, and then do your final restoration. Okay, SDF is very messy, so put Vaseline all over the patient's face, especially if you're working on young kids, because they will move, and then they will get a temporary tattoo from the SDF. So put Vaseline everywhere, even for yourself. As soon as you apply SDF, throw out your gloves, throw out all the materials you use. Because it will stain your counters permanently, and your clothes permanently. And the final tip is after you place SDF, you have to wait at least 2 weeks before putting a light cure material over it. So SDF is fantastic at arresting decay. If you apply SDF and 2 weeks later you apply your second layer of SDF, it has a 91% chance of arresting decay. That is fantastic. It is so cool. The lesion becomes rock hard afterwards. So after 2 applications, then you can wait another 2 weeks and then place your composite if you want to do that over top of it. Okay, here's another case of mine. So this was a very precocious, 2.5-year-old. She had decay in her front teeth, even intraproximally on her lower teeth. So her mom said, I do not want general anesthesia. And then I gave her the option of SDF. So that's what it looks like. You can see how big the lesions were at the back. And look how happy the kid is. She was telling everyone, I have silver on my teeth. Dr. Sanj is my dentist. This isn't great advertisement when, your patients walk around with black teeth. But then it came to when she started kindergarten, kids started teasing her. And that's when her mom said, you know, she's not cooperative for treatment. Can we just, get the treatment done under general anesthesia? Because look what it looks like on the front teeth. So this was easy to do, in 2022 during the pandemic. We're all wearing our masks, but now I'm getting a lot of parents complaining of the stain on their child's front teeth, and they're saying their kids are being bullied. So now I don't place SDF on the front teeth. What I'll do in lesions like that, when the parents don't want GA, or it's just a couple of lesions, not worth it to put the kid under GA, is I will use fluoride varnish. So this should have said fluoride varnish, not fluoride resin. So I use Profil fluoride varnish. And the reason why I like Profil is it's not sticky. That's right. It's 5% sodium fluoride. It's not sticky. It tastes great. The patient doesn't feel like they have nail polish bits on their teeth. They're not gonna like vomit and spit afterwards. I use this on babies a lot, and they don't even squirm or complain after. So it is a great fluoride varnish. There's no rosin in it, so there's no sticky stuff in it. It's not gonna clog your saliva ejectors, and it's not gonna irritate your patients. So I have a lot of patients who say they don't want the fluoride varnish, not because they're anti-fluoride, but because they hate that sticky feeling from the fluoride varnish. Well, introduce this and they won't even know that you put it on their teeth. And the great thing is if the hygienist puts it on the patient's teeth and you do the recall exam after, you can still see the teeth. It looks like water on their teeth. Let's talk about dental sealants. I do a lot of dental sealants. So if I'm doing a restoration on a tooth, then I'm going to be doing sealants on the molars, because patients who are at high risk are people who have oral hygiene, cariogenic diet. If they've had a cavity in the past 3 years or currently, they're at risk. So I will place sealants. Also, if I'm going to do, an occlusal or occlusal buccal or occlusal buccal lingual on a molar, I'm going to go around to all the other 3 molars and place sealants. Because if they're getting a cavity on one molar, they're going to get cavities on the other molars. So let's look at the evidence. Cochrane, this is systematic reviews, the highest level of evidence, says Fisher sealants are effective in preventing caries in children and adolescents compared to no sealants. And the CDC says that sealants protect against 80% of cavities for 2 years and continue to protect against 50% of cavities for up to 4 years. So you're probably thinking, well, 50% 4 years, not great stats. Well, let's rethink of how we classify whether a sealant is successful. How do you determine whether a sealant is successful? It's that there's no decay. So it doesn't matter if the sealant has come off, as long as there's no decay, that sealant was successful. And that's because after you place a sealant, little bits of the fluoride from the sealant, that sealant material goes to the base of that groove, and it's going to protect that tooth for much longer than it had the sealant on for. So if it lost its sealant after 4 years, that sealant is still working at preventing decay. Here are the sealant materials that I like to use. 3M Clint Pro, which changes color when you cure it. It goes from pink to white, so it's easy to see where you're placing it. Conceal F is a sealant where it's a lower viscosity than other sealants and has a thinner tip, so it can get really deep down into those pits and fissures. Clint Pro and Conceal F are resin-based sealants, so you need to have a dry field. Bougie Triage and Reaver Protect are glass ionomer sealants, so you can place these on partially erupted teeth. You're not worried about having a dry field. They like moisture. So here's another poll question. Lisa, please. Which dental sealants is better? Glass ionomers, resins, or there's no difference? Answer there. Good. 41% of you said no difference. That is correct. I know that we had some split answers there. So let me explain the difference. There is no difference. So glass ionomers have the advantage of releasing fluoride, a lot of fluoride. Resin has the advantage of retention. So even though the glass ionomer resin is going to be lost earlier, there's still, it's still fluoridated the tooth. The tooth now has fluorapatite instead of hydroxyapatite. It's stronger than it was before. Resin lasts longer, so it can physically protect the tooth longer. So when you weigh the pros and cons of each one, it actually works out to the same effectiveness. So use whichever sealant you want. However, if you use a resin-based sealant, make sure it's a dry field. And resin-based sealants also have fluoride. They just don't have as much as glass ionomers. Resin infiltration is not done as much anymore because now we have guided enamel regeneration with Curodont. So use Curodont for those early enamel lesions. So to summarize everything I've said so far, you can check out my article. It's on Canada's National Dental Journal called Oral Health. I wrote one article called Caries Lesions. How should we remove and restore them? And another one on how to stop cavities without a drill. And at the end, I will give you a QR code and you can scan it and you'll get access to all the resources that I talked about today. Okay, learning objective number 2, we're going to look at the best tools to use in challenging restorative situations. All of these challenges that we've had, like voids and overhangs. So I used to get a lot of these where my marginal ridge was too high. I used to get a lot of voids, underhangs, overhangs. I cured all that by getting Strategy Matrix. I'm going to tell you why it works so well. Like, look at these rings. See how it's curved? I'm just going to show an arrow. Because of the way it's curved, it automatically gives you the perfectly curved marginal ridge. And you hardly have to do any finishing and adjusting afterwards. And there's 3 rings that come in the kit. The short one is what I use the most often, the blue. So you can remember it as Smurfs are blue and short. The tall one is orange. So remember giraffes are orange. So it's going to be for taller preps. And for wider preps, I use the green ring. So the green ring is the only wide ring on the market, like amongst all the companies. So if you have a wide prep, use the green ring and you'll get a great contact. So the Hulk is wide and green. Use the green ring. That's how you can remember. But I just love my Smurf blue ring. So now I get contacts like marginal ridges like this. They're perfect because of the Garrison strategy. How about MODs? I sweat whenever I have to do an MOD, but with the strategy, I either use the butterfly technique where I put 1 ring on the mesial, 1 ring on the distal. This is hard to do if you don't have a lot of space on the distal. So what you can do instead is use the stacking technique. So I put the blue ring on first on the mesial, then put the taller orange ring on the distal, and then I pack the distal. So I restore the distal part. Then I take the orange ring off, the distal band and wedge off. Then I do the mesial. Oh, sorry, I leave the wedge in because I don't want bleeding. So I do the distal part, take off the band, the ring, and then I do the mesial part. So that is my technique for MODs. How about back-to-back restorations? They are so stressful. You want to get a good contact. The way to get a good contact and to do it fast and efficiently is with Garrison's Quad Matrix system. So I carry that in my bag as well. So the cool thing is the one thing is the wedge. Take a look at this wedge. It's almost like split 3/4 of the way through, and it fans out like wings towards the mesial of one box and the distal the other. And it has this really cool ring. I'll show you there. And it has a driver end. See the ring part on the palatal with the arrow? So you put that arrow on the palatal part and see how it splays the wedge apart. So now you have one part of the wedge going towards the distal, one part going to the mesial. So what I do is I restore both the DO and MO. So I'll restore the DO or the MO, and then I'll restore the other one. I do not take the ring off in between. So look how fast you're going to be able to work. You just put the 2 bands on, 1 wedge, put your ring on, restore one tooth, then restore the other, and then take everything off. You're going to get a fantastic contact. One tip here is do not use these quad rings for just a single DO or an MO because your contact's going to be so tight because of that driver that it'll be really hard to get floss in between. So use it for your back-to-back MODOs. My favorite bands are the firm bands because that way they're not going to be flimsy and bend. I'm not going to get frustrated. So I use Garrison's Fusion firm bands. And if I'm having trouble getting the wedge, getting the matrix, they're also flimsy, topping over, popping off, then I will pull out my Garrison band and wedge forcep. It's quite strong. It holds everything in place. So I'll just use that if my cotton pliers are frustrating me. Another thing that frustrates me is, say I have the rubber dam on and I'm doing a restoration close to the clamp. I put the ring on and it pops off. So what I do instead is I use a thinner ring, and this is called composite type from Garrison. Interiors, I hate doing class 3s. I used to hate doing class 3s because the mylar strip would move all over the place. I'd have to spend so much time adjusting the restoration. Now I just use Garrison's Fusion Interior Matrix System. It's a metal band. It stays in place, it sticks under the gum. If you don't like using that, you can use a Veristrip, which is a mylar strip, but it's curved. Why didn't I think of that? So I love Garrison's solutions for all of our restorative problems. How about subgingival preparations? Okay, so Matt Najad, this is his case. You can see here, he did his subgingival restoration in 2 steps. And you can see he used different materials as well. So in the subgingival box, it looks like he used a glass ionomer type restoration. Then he took the band off and used a regular band and did the rest of the preparation. So this is a great way to get a good contact because if you do it the usual way, look at this. A lot of my restorations look like this because I'd put the band on, stick the wedge in, and I'd get a void. So here is another system from Garrison. It's deep margin elevation, where you get this really like thin band that's not too high. You put it subgingivally, do the base of your restoration. Once your base is done, you take the band off, put a regular band now, because now you have a regular looking class 2 restoration. And now it's much easier. Okay, so our last poll question, what material would be best to restore a deep endodontic access or a subgingival box? Because the light's not going to shine deep down. So what are you going to use? Most of you said self-cure composite. That's what I would use. You could use amalgam because the amalgam doesn't need the light, but amalgams do increase the risk of fracture. Resin modified glass ionomers needs the light. The light's not going to go down that deep. Composite resin needs the light. The lights don't go past like 4 or 5 millimeters. So if you have a really deep prep, use a self-cured composite. You can also use a regular composite over top if you want, or use a self-cured composite for the whole preparation. Reducing post-op sensitivity. Don't drill so much. Do selective caries removal. Self-cure composite resins decrease post-op sensitivity because you don't have a gap between the restoration and the tooth. It's a gap-free interface, and it releases a lot of fluoride. Have good isolation and a good matrix system, because then you're not going to get voids and open margins. To reduce voids, heat up your composite or use dual cure or self-cure composite, because then it's like gooey and it just like runs in and you don't even have to do anything. You just squeeze it in and then all the voids will be, eliminated. Because you don't have to pack different increments which can create voids. Prepping the tooth, make sure you bevel the margins because that's going to make it look better. It's also going to increase the bond adhesion. So instead of just doing a straight prep, like after I do my preparation, I take a football burr around the margins to bevel it. And now I have a better bond between the filling and the tooth. Also, when you prep your tooth, see this picture on the bottom right, how, the margins are splayed out a little bit, because if you just do a straight prep without flaring the margins out a little bit, then your preparation's not going to be self-cleansable. Whereas if you splay out your margins, then it's going to be self-cleansable. You can see the margins and polish them properly. Your patient can clean those areas properly. Fluoride can get to them. You're going to reduce, marginal leakage and recurrent decay. Another tip is before you start restoring your preparation, just grab your PFI and make sure it fits into the box, because there's so many times where I made such a conservative prep and I etch and bond and I'm about to put in my composite resin, and then I can't get my instrument to condense the composite resin because the box is too narrow. So make sure your instrument fits into the box. Okay, I use diamond burrs because they're fast cutting, smoother finish, and you have less friction and heat. They do wear down faster than carbides, and they're less expensive than carbides. So just reuse your diamond burrs. And I use green for prepping, red for my adjusting, and then yellow for finishing. So my tips for restorations is check the occlusion with articulating paper before starting, pre-wedge, so it opens up the contact, and then place the wedge on the side from the larger embrasure, and take your time to ensure the matrix, band, wedge, and ring are all placed well, because then you have to do less finishing. So this should say number 3. Our last objective is the rubber dam. Patients actually like the rubber dam because they don't have to worry about, like choking on their spit like SpongeBob's doing here. So I just use 2 clamps, the 8A clamp when I'm clamping a molar, a permanent molar, and the 2A clamp when I'm clamping a premolar or a primary molar. That's it. 2 clamps. I make it easy. I just use very inexpensive dam like Isodam. It works great. I pre-punch my rubber dams to save time. If it's one tooth, I just punch one hole. Otherwise, I'm doing a whole quadrant. And I find that the big suction is too big to suction around when the rubber dam's on. So I use this called a Tipadilly. It's a high volume evacuation system with a smaller tip. I used to think that rubber dams were superior, but this article shows that after 6 months, it doesn't matter whether you use rubber dam or cotton rolls, the success rate's the same. So if you are going to use cotton rolls, I would recommend putting 2 on the lingual, 1 on the buccal, and using dry angles where you have the metal part towards the buccal, and keep replacing them as they get wet. However, I like rubber dams. I also love these. I use Vaculux and Dry Shield at my offices. These are great because this is a picture of a patient on the left that I worked on Saturday. And it's great because I can work on her upper teeth and lower teeth at the same time. It's safe for her because nothing's going to go down her throat. The suction's attached, and my assistant, it doesn't have to worry about suctioning. She was able to, prepare everything for the restoration. So it's fantastic. I still use cotton rolls on the lingual and buccal, but I use high volume isolation all the time. So my isolation tips, even with rubber dam, I'll place cotton rolls underneath. I tilt the head one side to another, up and down, just so the gravity pulls the saliva away from my preparation. You can use rubber dam sealer if you have any voids in the rubber dam. I use a Tipadilly high volume evacuation when I use rubber dam. If you're getting fluid from the tooth, make sure that the matrix band is snug against the adjacent tooth. So that way you're not going to get any blood or gingival cracker or fluid coming in. So the matrix band has to be snug. You can also use your traction cord dipped in Hemodent or Teflon under the gum if you're getting a lot of gingival curvicular fluid. And my favorite was thing. have Sealant, Conceal F, Propyl Fluoride Varnish, SDF, my dry shield. My favorite rubber dam clamp is the 8A. Neoputty MTA, which I use for pulpotomies, partial pulpotomies, direct pulp caps. Ionoseal for indirect pulp caps. I use the Strategy Garrison Blue Ring for most of my restorations. If it's back to back, I will use the Quad Matrix. Here's another QR code. If you scan this, you will get, a little download that has links to the articles that I referenced. So thank you very much for tuning in. And now's my favorite part to answer your questions.
Do you use Caries indicator?
No, I don't. Great question. If you like to use it, please do. But I find that I'm very comfortable checking decay just with my Vision and my Explorer.
How is the Class 5 GIC longevity relative to composite?
Actually, it lasts longer because, like that article that I showed you, it had better retention than composite resin when it came to class 5 restorations because it has that high flexural strength and chemical bond to the tooth. It lasted longer because of that area of the tooth, that cervical area, there's a high flexural stress load there. So you want to use a material with a high flexural strength like glass ionomer.
What material was used on the slide with Jeff Knight?
With the subgingival restoration. I'm going to have to look it up, but it looks like he used glass ionomer at the bottom, like a sandwich technique, and composite resin on top.
Have you
I'm thinking
used,
that's the one. Oh, actually, sorry, that was Matt Najad did the subgingival. Jeff Knight. Oh, that was the class 5 restoration, I believe. I think that was resin modified glass ionomer.
have you used Riva Star Aqua and does it really not stain the teeth?
Okay, great question. In Canada, we don't have Riva Star Aqua. We just have Advantage Arrest, but I have used it when I've done volunteer work, and it will turn the tooth gray, but it'll still discolor the tooth. So I will not put it on interior teeth. I'll do it on back teeth and looks fine. So at least it doesn't turn the tooth black, but it'll be gray.
When completing a restoration using selective caries removal, are you finding radiolucencies on the radiographs? And are you ever worried that this might be recurrent or reactivated caries?
Yeah, that's a great question. If you're doing selective caries removal, the radiolucency should stay the same over time or decrease. If it's getting bigger, then that means you left some of the infected dentin behind and you have to go back in. I've been using this technique since that article came out in July 2023, and I had great success with it. I haven't had to replace any restorations. The only thing is, if the patient switches to another dentist, the other dentist might think it's recurrent decay and remove the restoration.
Which curing light do you recommend?
Oh, very good. So you should use, so I use I associate, so I just use the curing lights at my offices. I know that Garrison has a great curing light called Loop, which actually tells you whether you're too far away from the tooth. So I think that is a great curing light because then it gives you the information you need to make sure that you're curing the tooth properly.
Have you used Smart Burr from SS White for dentin infected?
Yes, I have. I've used lots of different burrs. I love SS White burrs and all the other types of manufacturers' burrs. It is best to use disposable burrs if you can for diamond burrs because they do break down pretty quickly and they are very hard to clean as well because of the rough margin. So just use disposable diamond burrs.
And how long to set in self-cure?
Yeah, so the Stella Self Cure takes 4 minutes to set. At the first, you're going to think like this is taking so long because, but the thing is, like when you're doing like a lot of restorations back to back, deep restorations, they also take 4 minutes. So what I do is I tell the patient it's going to take 4 minutes. Just going to let you sit here while the material sets. And then I write my notes and my assistant cleans up. And then after my notes are done, the material's set and then I finish it. So, but it's 4 minutes to set.
Thoughts on bio LCB liner base?
I'm not familiar with that. I'll try to, can you spell it out, Lisa?
It's just the acronym here, so
Oh, okay. Oh, I'm so sorry. I can't answer that one. But if you're thinking about biodentin is a great product and you can use it as an indirect or direct liner.
okay. And then we have you may have answered this already, but we have somebody asking for what was your favorite self-cured GI again?
Well, my favorite self-cure GI is Riva. It's from the company SDI. And the reason why I like Riva is it's very easy to handle, doesn't stick as much, and also it has 10 times as much, sorry, 4.5 times as much fluoride as the competitor glass ionomers.
Okay, a lot of thank yous. Somebody is asking, could you put up the okay, so this
Oh,
is
I
the
put the
handout.
second QR code. Yeah,
Yeah,
I just,
yeah. Okay. And then last question is it's more of a comment and a question. So class two direct restorations are some of the most challenging work in restorative dentistry, yet
agree.
it
I agree.
pays terribly under insurance plans. And moreover, this is an aspect pushed by advocates of dental therapists. Why, in your opinion, why the gap in reality?
Yeah, I totally agree. I think preventive procedures like sealants, SDF, Curodont, they should incentivize dentists to do more of them because they're preventive. They will be better for the patient. People would do more sealants if they were paid more for them. And yeah, our class two restoration is even more difficult than an extraction, but you get paid more for an extraction. Doesn't make sense. I don't know why. I wish we can change things and make the more frustrating things more expensive. And that way, it totally reimburses you for the time, stress, all the materials that you're using. So I wish I can make the fee guides out there and reimburse everyone properly.
Okay, and this really is the last question, and then we'll close it out. How
Okay.
can you use Activa dual cure bioactive resin?
Yeah. So I have used Activa before. It is also a great product. However, I like using pure glass ionomers like Riva because you get way more fluoride. So with Activa, you still have to etch and bond. So when you're doing that, that means it's not a pure glass ionomer. So pure glass ionomer means you're going to prime it, place a glass ionomer, and then you can put a coating over top of it once you finish it.